Hi, everyone. This is so exciting to come to another very big milestone for the EU CAIASNet project, the European Network of Youth Cancer Survivors. Welcome, everyone, and thank you so much for joining us this afternoon. We have a stellar panel to share with us today the findings and the outcomes of nearly 2 years of work in this project, and not only. So before we dig into the topic today, I would just like to say a very, very warm welcome to Professor Winette van der Graaf from the Netherlands Cancer Institute, who will give us a little background on cancer in adolescents and young adults and why are we consider them a very specific and special population, and why we would like to make sure that we focus on them and that we describe some very important needs in their clinical care in order to make sure that they will have better clinical outcomes. We also have with us today Dr. Urska Kosir, who is part of the Youth Cancer Europe Network and also has been leading this work within this work stream. Professor Daniel Stark, a long-time collaborator from the Leeds University, also participating in many other projects relating to adolescents and young adults, and is heading up the Anti-ACT network dedicated to the study of this age group. As well as Anna Totovina from Romania, who has lived experience as well and who has been leading this work stream in this project. Thank you so much for all the work that has been put into this. Today must be a celebration and a very big day for you, Anna. We will hear from all of them and also from a very special patient panel who are obviously more than just people with lived experience, but also professionally working and passionately contributing to this subject. A very warm welcome to Sophia Sleeman from the Netherlands, to Tim van Hoorenbeke from Belgium, to Massimo and Adelina joining us from Italy. And then, last but not least, we will also talk about implementation. Once we speak about the recommendations that we would like to put forward as a result of this project, we also want to delve into the future a little bit and how we foresee some of these recommendations being implemented in different healthcare settings around Europe. So for this, we welcome the IO Care Network leader, Dr. Evelina Montenhorst, also from the Netherlands, Johan de Munter, who is also a president of the European Oncology Nursing Society, and he's the clinical nursing director in Ghent from Belgium. We also welcome Dr. Rodica Kozmarovic from the Cluj Oncology Institute, and Dr. Tanja Spanik from Slovenia, who is the head of Europadona Slovenia, and Professor Daniel Stark will also contribute to this conversation as well. So without any further ado, let's dig into it. Let's get started. So I would like to invite Winette to please talk to us about why adolescents and young adults are special. We know that they are special, but from a clinical and medical point of view, please tell us.
Huge. Yeah. Thank you, Kati, for this very kind introduction. And congratulations for organizing this webinar. I know it has been a lot of work, so really nice that we are together all, and I see a lot of colleagues and patients from the field very active there. I'm happy to introduce AYA, well, oncology in a nutshell. I have only 10 minutes, so I can only highlight most important things, which are maybe the fundament of organizing AYA care units in the different countries.
Yes.
So with that, I will start my second slide. Yeah. So young patients with cancer, we can already think of really children, and they belong to pediatric oncology. And in general, we mention them as patients diagnosed between almost birth and 18 years. And for them, the care is in general relatively centralized. Some are very centralized, like in the Netherlands. But it differs already when you become a teenager. And since long, there has been TYA services, especially in UK and France, for patients aged 13 to 24 years of age. And they have done impressive work. But when you look at it in more detail, they are mainly supervised, not only, but mainly supervised by pediatric oncology. And TYA and AYA are a bit mentioned. Someone is calling it TYA, others AYA, but nowadays there's a kind of international definition that patients are called AYA, adolescent and young adults, when they are diagnosed between the age of 15 and 39 years. And they are, as you can expect, treated by pediatric oncologists, but mainly by multidisciplinary teams in adult oncology. And the challenge there is something that we will address this afternoon. So what can you expect from patients at this age group? What you can see here is an age range here on horizontal line. And you see here that there are tumor types that are mainly occurring at pediatric age. So we know these tumors, like some form of leukemia, that's occurring mostly in young children, but they can occur also in young adults. What we typically see as patients with diagnosis from AYA age are patients and often females with thyroid cancer. Melanoma is seen relatively often at this age, and also germ cell tumors like testicular cancer and tumors of sarcoma, so bone and soft tissue tumors. But more and more we are seeing, and especially towards a bit the older age range of 15 to 39, that we see tumors that we are generally well known as a diagnosis with elderly patients or older patients, like lung cancer, breast cancer, GI, so think of colon cancer, for example, and others. And what we see nowadays is that these patients, that this here is an increase in incidence, and especially something like colorectal cancer is a tumor that we see more often nowadays, also in young people. It's still rare, happily, but there is an increase. So we have a mixture of tumors, as you can see here, and we need a lot of people to treat these patients because they have all different diseases. So what can we see then, if it works? And you give me the next? Yes, thank you. So if we look at more in detail what you can expect as tumor types, and then here we start with male, and here this big one is about testicular cancer. That's by far the largest group in this age range. Melanoma, we see often cancer of the GI tract, so colorectal, and here we see lymphoma, and all the rest you see is more rare. Next, yes, here in female cancer, the biggest one is formed by breast cancer patients, and you see here also melanoma, thyroid cancer, and then a lot of others which have a less high incidence. I also see that someone has used my slides for the nice format, but therefore it's less readable than I had before. Anyway, I hope you can see it still. Here you see a rising incidence in males and females. So that's what I told you. Here you see 1989, here's 2020. These data are based on figures we have from the Dutch Cancer Registry, and you see here in the males there's an increase in numbers. That's mainly due, by the way, to a rise in testicular cancer, and in females there's also a really huge rise, and that's also more, well, not only but also breast cancer there. Happily, the good news is that there's also that there is an increase in survival. So although the incidence has increased, so more patients get the diagnosis at young age, the survival of those patients has really improved. Here you can see in blue, that's between 1990 and 1999. It's the oldest decade where we look at, and then you see here from 2000 and here from 2010. And you can see that the survival here for all age groups, so these are the young AYAs, and here you see the more older, but in all age groups, both in males and in females, the survival has improved. So that's good news, but that also has consequences because we will have more survivors, happily, but they will face some issues I will address later. So here you see that it's also a difference between the tumor types. Some really have a very good prognosis, like here testicular cancer and breast cancer. Well, that's and you see here thyroid cancer has a very good prognosis. Lymphomas, but you also see, and that's important to know, but happily there are tumors that don't occur that often, like trachea cancer, that's very rare, that has a very poor prognosis. But if you look at more GI cancers, cancer of the stomach, of the liver, of the pancreas, they still have a very poor prognosis. So there's a lot to do for those patients. Next, please. Can I have the next slide because it doesn't work so well?
Yes, sorry, you are not able to forward the slides, Winette. If
No.
you press on your arrow or on your
No.
Okay,
yes,
sorry, that
thank you.
please help with this. Thank you.
So why do we need special services for AYA cancer patients? That's in fact the topic of today. Well, I think it's important to realize that in the adult oncology field, patients at this young age, below the age of 40, are very rare. In total, they form only 3 to 4% of all adults who are in hospitals with a cancer diagnosis. So they are invisible and they are dispersed between many different disciplines. The survival is good, and there is nothing organized for good holistic care, so psychosocial care, etc., which really address their age. So we really need more early holistic care and interventions because they may prevent later what I call health consumption, but I mean that people don't need to go to the psychologist. Maybe if you have had good care from the beginning. And it's important to realize with a long life ahead, a good survival, that treatment of today may have lifelong impact and risk and consequences in case of side effects, for example. And there are survivorship issues because you are not the person that you wanted to be. Next, please. So in the past, AYA oncology was mainly, as I call, teenager and young adult care. It was driven by pediatric oncologists, and in the pediatric oncology, this whole care was more holistic. It means you don't have only a doctor, you have a specialist nurse, you have a psychologist, a social worker, and they also take care of your parents. That's totally different in the adult oncology field. And there are other things like pediatric oncology is more centralized, more trial participation, and the tumor types are different. So in general, there are long chemotherapy schedules, part of pediatric oncology diagnosis. Next, please. So what in AYA oncology? There is not this psychosocial care. Patients are treated almost everywhere in the hospital. I showed you all the different diagnoses, so different medical specialists. No specific centers exist like hospitals. So you need to build the care in the existing care in the adult oncology. And then the question is, who cares? Next, please. And another issue is that pediatric oncologists see much less new patients per year than do adult oncologists, and that's just a matter of fact. But it also has to do with the time that a doctor can really invest in a certain patient. So if you can't do it yourself, someone else need to take care of all the other issues that you may have. Next. Well, what do they have as questions? Well, we did ask in the Netherlands patients what they would like to have if we built up a new service. They said we would like to have an own space in the hospital, contact with peers, also outside the hospital, because in the hospital I only see my, well, people that I have the age of my grandma. They would like to have very much focus on fertility, education, work, romantic relationships, life insurance, mortgage after this treatment, and late effect of cancer. And next slide. And altogether, they had these topics, as you can see here. Also sports, diet. Diet is something that you really can be on top of. That's something you can be in the lead of. So this is really something people often would like to be involved in what best they can do to prevent late effects or having a second tumor or whatever. Next, please. So the organization of care in adult oncology addresses the question on how to address and organize care in adult oncology setting, where patients and doctors are at many different departments in the busy oncology clinics with mainly all the patients, and by whom. There are experts of the disease, but these experts of the disease are really not always experts on AYAs. Psychosocial support, should we organize it in the hospital or elsewhere? And multidisciplinary tumor types are available, but are there also multidisciplinary AYA dedicated teams? Well, that's important to think of when you organize adult AYA care in the adult oncology field. Next, please. So coping with the disease and age-specific issues is really an issue of this age group. Late physical and psychosocial effects of treatment, the risk on second tumors is increased. So who takes care of that? Is that something to worry about? Who can give lifestyle advices? So who will discuss these issues where and when? Next, please. When setting up a new service, there are other aspects to discuss. That's finding the optimal age range in your healthcare system. If you have organized it like in the UK, where you have TYA units until 24, it's different than in many other countries where you don't have these services. There you really have to start from 18 or maybe even from 15 to organize a service. Which issues do you want to address? Is it all hospital-based or can the GP do something? And whatever you do, do it together with patients and their loved ones, because you organize it for them and let them give their input on what they want. What's the number of patients you can expect? If it's a low or high number, in general, it's a pretty low number in the whole adult oncology field, but very important. The diagnosis you have to consider, you see in your hospital, where are these patients treated? And lastly, but very important, who will fund your initiative? Next, please. I would like to end here because I know there will be very interesting answers to these questions this afternoon. And I would like to thank and also congratulate the Youth Cancer Europe with a nice EU grant and all the work they have been doing on this grant until now. And I'm also happy that you are part of another EU grant where many of us are involved in, Strong AYA, where we really would like to collect data in this project in the end that can help build up AYA services. And with that, I would like to thank you.
Thank you. Thank you so much, Winette. For all of this. Sorry, Professor van der Graaf. It's really, really good overview. It's nice actually that we have this long ongoing friendship and collaboration within the AYA oncology ecosystem in Europe. And I would really like to applaud everyone who has been leading the work. And you have been very inclusive and always thought of including patients in this work. So the current work that we have been doing within this project was only possible because of the support that we have received from all of you. So thank you for acknowledging that there's a lot more work to be done. There's a lot more research that needs to be done, clinical research actually for this age group. And you also mentioned the need to focus on holistic care, and we will be alluding to this. And you also acknowledge that there's a very, very big difference between a pediatric or adult care settings treating these AYAs. So I think you have given us a very nice introduction and a segue to go into how we've built this work in this European project. So I would like to invite Urska, Anna, and Dan to give us a little introduction to the work stream and the methodology and, you know, all the very important topics that we have actually focused on before giving our recommendations. The floor is yours.
Thank you. I believe we have some slides, don't we, Anna? Yeah.
Yes. And you have the control, Urska and Anna, so you're able to click next.
Okay. All right, so I guess I'll start. So thank you all for coming, and thank you for such a great introduction to the topic that's very close to my heart. I've been in it for the past 8 years or so, also a person with lived experience. So this work is really a culmination of 2 years, and I cannot believe we're already here. It's been a lot of things back and forth, and one thing that we really managed to do here was to put patients in the driving seat. So the paper that resulted from this work has 5 main components, which are listed here. So we began by a literature review. We looked at all the peer-reviewed evidence that's already out there and published. We also did a fair amount of gray literature review. There's a lot of resources for young people, as you might know, that are available on the website that are not necessarily peer-reviewed, but contain a lot of information that people rely on. Then we have actually come up with our own method, which we believed was a better way to integrate young people. It's called peer visits. There was a whole work stream dedicated to that, and Anna can speak a bit more to it. But literature review really informed the peer visits. So these are subsequent steps. Peer visits were kind of like a smaller groups of patients that we got together. And I've led some of the work where we introduced young people to the medical research, to the ethics of it, and then brought them to 3 major hospitals so that they actually actively participated and became observants and participants and researchers themselves, which was really crucial in gathering all the data so that we don't always have a very one-sided view. It was young people collecting their data and being researchers. During the peer visits, we also had individual interviews. We got a lot of rich qualitative insights and some more quantitative reports. All of those insights then brought us to the Delphi process. Some of you might have perhaps responded to it. We ran 2 rounds. I'll briefly show some of that in a second. And then it culminated in an online roundtable, which Dan will speak to. And the QR code is there for you to access on OSF. We posted everything transparently. The whole process is described in much greater detail than I have time for. So just a visual representation, really, like I said, these steps are building on each other. The literature review, the greater literature review really informed all the items. We scanned the work left and right, up and down to find items or domains, topics, concepts that are important to young people, and then systematically and thematically group them into this comprehensive survey. So say mental health, career support, as you can see. And then that then informed the Delphi items, which some of you might have seen, where in the first round, we asked participants. So participants were young people with lived experience and healthcare professionals. We asked them to rate the importance from 0 to 10. And then in the second round, we asked them to rank the same items. Of course, we also gave the option to provide any more items. The literature review, it was conducted between December 2023, actually October and December 2023, so a while back, but continuously we kept on screening any new publications that came up. It's a topic that's quite popular. There's a lot of work coming out regularly. So like I said, peer visit, I'll turn to Anna to briefly maybe describe a bit more what went on.
Yes, so what you're seeing here is actually the peer observation form that was made after we did the literature review. I don't want to talk a lot about this because we prepare a video of 3 minutes for you to see everything that was done in the hospital. So I would like to go to the next slide, Urska, and they will see the video about it.
Wonderful.
Mm-hmm.
Is this the video or?
No, it's gonna happen in the next panel when we will talk with the
okay, wonderful. Thanks for clarifying. Yeah.
Yeah, and you can go with the qualitative reports, and then we can go with the.
So again, peer visits are also it might be a foreign concept for now, but it's really a method we put together. You can read about it also on the QR code that I posted earlier. But to delve into a bit more details here, the qualitative reports, which also informed our writing of the paper, were kind of divided into 2 sections. As I already mentioned, young people visited 3 hospitals, or actually various institutions, more than just 3. And we asked them to then report to us. They acted as researchers. So we asked them, okay, what were your findings? So they came to us and we gathered these observations from many different perspectives. And you can see all the detailed questions online. But we wanted to see, okay, so you visited this clinical setting in which AYAs are treated, say in Belgium or Milan, in Italy. Can you tell us what were the strengths, what works, what doesn't work, what really stayed with you, so that we can then promote that at the European level. And in the section 2, we just wanted to go a bit beyond and ask these people that then had such a rich experience also, can you describe components more generally that young people want in their care, what is relevant, what's useful. And that again informed the writing. And then we got to the Delphi, like I already said, the items were grouped thematically, a lot of them. And a slight note, the Delphi was combined with Strong AYA project, which is another project ran out of NKI in Amsterdam. We know there's a lot of work happening all at the same time. So we wanted to lessen a bit the burden on the same participants. So we combined the Delphis. And yes, so we had those items. This is an example of how it looked. We asked people to rate the importance. Here we have an item from mental health to rank how important the psychological counseling is at every appointment where young people go. The second round, again, it was done. There's specific dates. I won't go into details of those. Like I said, it was actually out of Southampton that those were sent. We asked them to rank the items. And then what did we do with this data? All the results, this is just a quick summary. All the results are also online. We hope to maybe publish some more. Please come to us with questions. There's a lot of important information we have. But in the round 1, we just see density plots where AYAs in purplish color and healthcare professionals in yellow color. We can see the distribution of answers from 0 to 10. We don't see the numbers at the bottom, but 0 is on the left. And 10 being the most important is on the right. So just to observe any discrepancies, a lot of the items had similar distributions, and the lines are actually the medians, so the most common response that people gave. In the round 2, like I said, we were asking to for people to rank the importance of items. So we just did an inverse normalized weight. So the highest ranking received the highest score, and then we summed them up. And again, it's just to find any discrepancies, any differences between how the AYAs and HCPs rank items. And then I thought it would be very neat to actually have these 2 dimensions in a single plot. And we've done this for every single domain of items, a lot of work, a lot of data. On the left, we have young people with lived experience, and then we have healthcare professionals to see how the items might differ in terms of importance on the x-axis, and then the ranking on the y-axis, to give us a sense what's really important to young people and healthcare professionals. Are there discrepancies, where, and so on. So here is just an example from the built environment theme. We saw that young people really emphasize having AYAs around, having their peers around is very important. Healthcare professionals, interestingly, thought having a private room for parents is important. So slight discrepancies like this were revealed, which are really informative. And as I said, this is all in a format now online, available for you to review more closely, and it really has informed our writing. And we hope to continue working on this, but we have all the data for our statements, which I think is very, very powerful. And with that, I'll pass the word on to Dan to talk about the roundtable.
Thank you very much indeed. So I hope everybody can see and hear me. Have we got? That's fine. So in the early December of 2023, we ran a roundtable that brought together a whole series of experts to discuss how we would upscale AYA cancer care across Europe. It was run virtually. It was very successful with a very high participation. I seem to remember a similar, or if not larger than this particular group, and we had very great experts on the panel. I was lucky enough to be asked to chair it alongside Katie. Have we got the members of the panel on a slide there, or I can talk to that?
No, you can name them if you want on the
That's
next
lovely.
slide.
So we had Ulrike Leis and Johan de Munter, who's on today, Karina Schneider, Andrea Ferrari, and a number of representatives of Youth Cancer Europe. We had as a special contributor Jan Willem van der Loo from the GG Research and Innovation group in the Commission. And we came with a series of key takeaways from a in-depth and detailed discussion and debate. We wanted to advocate for unified funding strategies that covered AYA cancer, including children and adult oncology. Sadly, across Europe, the ways in which services such as this are funded are different, distinct, not necessarily easy to navigate or negotiate or get the funding that's required to provide this key and important care. We talked about collaboration. We took away the need for AYA care to be collaborative, to have engagement from paediatricians and engagement from a range of adult oncologists and other specialists within units that provide this AYA cancer care for comprehensive care to be delivered. We heard more about that from Winette earlier on. We talked about and concluded that there was a need for processes to support staff recruitment and to train expert staff to work with adolescents and young adults. We have expert staff who deal with children with cancer and are focused upon that and trained in that. Then we have adult cancer expert staff, and for most of those, the majority of their cases are much older, and so they gain expertise by experience and by working together in dealing with older patients with cancer, and it's harder for them to gain expertise in adolescents and young adults. We talked about utilising partnership across Europe and European Union funding to transform health and care systems. And one of the areas where this goes forward in particular is the joint action for networks of expertise, which are being built across European hospitals and nations at the moment to improve AYA services. And another is obtaining funding for further research programs after this one to further study and answer the questions that projects such as this lead us to want to answer next. We talked about what age range we wanted to deal with for adolescents and young adults with cancer, and whether we wanted to stay with the 15 to 39 bracket that's generally in use, or how we dealt with the challenges of that for some European nations where a different age range has been studied so far, and how we transition from the age ranges that are being studied at the moment and where services are in place to other age ranges if we want to. We talked about legislative changes to ensure therapy is available for adolescent and young adult patients as soon as it's proven to be effective. If it's not yet proven to be effective, access to clinical research is very important so that patients can try and can use those medications whilst they're promising but unproven in a protected, safe research environment, rather than other softer systems which are harder to learn from. We talked about the importance of patient involvement in decision making, the importance of networking, knowledge exchange, and comparing the outcomes in different European centres, and that's something that Strong AYA is very interested to do. And we talked about transparency. We talked about making the management, the cancer management options that are available in younger children and available in older adults, available to adolescents and young adults who were to be aware of those treatments, for their doctors, nurses and clinical teams to be aware of those treatments, and foster through that access to research by having awareness of the research that takes place. So we concluded that work roundtable with an excellent call for action, and I believe that the next best place to take this would be to what that call for action is, and some maybe the videos and things that you've got in mind, Anna.
Yes, so next, going to the next panel, I would like to share a video to show you how was the experience of the young people in the peer visits. Also, the general report of the peer visits and of the roundtable, it's available on beatcancer.eu, so you can read there the reports. And Asta, if you can share the video, and then we will go to the next panel and talk with the patients that participating actually in these peer visits.
Lovely, very good, super, super exciting. And because we spoke so much about the methodology and the background behind putting together this new publication, our recommendations, and everyone alluded to these mysterious peer visits and the path, the peer observation forms. We thought it's really important to actually give it a little bit more context and explanation. Obviously, everyone sitting in this panel has also contributed to other parts of this work. And as we said, there was a literature review, there was the surveys, the Delphi roundtable, very consultative process and very collaborative process the whole time. But peer visits were a very big part of this. And well, I'm going to ask Asta to actually bring up the Slido question, because we would like to know who is in the audience. And maybe what do they know about the subject, but, you know, firstly, you know, whether they have lived experience or not, and then also maybe some understanding of the geography of who is here. And because I see 83 people in the audience, and by the way, I would just like to note that the number of participants has not dropped from the beginning. So yay, kudos to our presenters so far. I would actually like to speak with all of you. So when we were designing the project, we were thinking of visiting different settings, right? So there's a difference between the Netherlands and Belgium and Italy. There are different delivery systems there, and there is a different maturation level of the AYE care and the AYE care concept in these different countries. So if you don't mind, actually, I would like to start with you, Sophia. You were very, very much involved in designing the peer visits and peer observation form. Can you tell us a little bit about how you came into this project? What was your vision? What was driving you? And then, you know, how did it actually roll out? Because you were our host in the Netherlands, actually.
I was, yes, thank you. So I first enrolled as a participant, as a patient advocate, a person with lived experience, to just, well, broaden my horizon, to see how everything works in different countries and get inspired by other systems, and also just meet other people from different backgrounds, what their life's like, what cancer is like for them in their environment. But as the project continued, I found out that you guys were planning on visiting the Netherlands. And I work for a couple of different organizations in the Netherlands that focus on AYA care and support. So I kind of like butted in a way, like, where are you going to visit and can I help? And so we set out this really nice program where we got a really nice overview of what we do in the Netherlands, because we have an actual system, a network from hospitals, not just one hospital or two hospitals working side by side, but many, many hospitals within the country that contribute to AYA care. So I wanted to give you guys, the peers that were visiting, a little bit of an overview of different hospitals within the network. So we visited 3 different ones that contribute on different levels.
Yeah, thank you, Sophia. So we really appreciated that. And there was actually a very strategic thinking in choosing those 3 different sites as well.
There was, yeah. So we visited one of the, as we say, knowledge centers for AYA care in the Netherlands. And this was also the University Medical Center that started with AYA care in the Netherlands. So we could give you a bit of a history line there, how it all started, where it came from, who was involved. And then we also visited the NKI, I always struggle with this in English, the Netherlands Cancer Institute, where we have just one hospital that only sees cancer patients. So that's also a different approach than a hospital that sees different diseases. And we also visited a regional hospital that sees less AYAs than a university medical center. So you get a really nice taste of different flavors, really, yeah.
Thank you so much. And Sophia, if you don't mind, let's just travel a little bit onward then to Belgium. And this was not the order of the visits, actually, but it kind of makes sense why I'm doing it like this. And I think it will also make sense for our audience. But please give us a little bit of insight, Tim, about where does AYA cancer care stand in Belgium at the moment? And then maybe also allude to your role in it.
So, hi everybody. Thank you, Katie. I think in Belgium we are on the verge of something big I'm sorry. I mean, we just had a very good federal minister of health who implemented cancer care centers in Belgium. So there are 6 university hospitals who will be responsible for providing AYA care in Belgium. And that is actually part due to a pilot project that was started in the healthcare center we visited, so in Ghent. So that is also the reason why that's the hospital we visited in Belgium. My role is really being a patient advocate. So I joined Kom op tegen kanker in 2019 as a volunteer. And from there, I gave my own input, talked to other peers, and tried to implement legislation so we can improve eye care as a whole in the country.
Thank you so much. And then Italy. So to be fair, the first country and the first hospital that we audited in this process during our peer visits was Italy. And Massimo, this concept was pretty new to you. And then Adelina, we actually only met you for the first time in Italy when we visited. And just so that we can take the slide down, let's acknowledge that we have a lot of people from Belgium joining today, and then from the UK and Ireland and Netherlands and Romania and Spain and North Macedonia. So we have mainly Western Europe. Okay, Macedonia, Portugal, Austria, Canada, lovely, Costa Rica. That's Carmen. Thank you. Germany, Latvia, Malta, very nice. Poland, Singapore, hello, and Switzerland. Thank you so much. And then maybe just and Turkey as well. Thank you, Albania, and 0 from Europe. So thank you so much, Asta, for this. And we also see that we mainly had, so we had 30-some% healthcare professionals, 20-some% people with lived experience, 20-some% people involved in patient organizations or patient advocacy. And then we had research and academia as well. So I think more than 40% of people very, very closely working with patients or with patient advocacy or patient representation, and then 30% healthcare providers. That's who we are on this meeting. But back to you, to our patient panel. So Italy and the deep waters that you were thrown into, Massimo and Adelina. We came to the hospital because we wanted to understand how adolescent and young adult care is being delivered. And also we learned so much, because we learned about how some things maybe don't have to take place in dedicated AYA units. Nevertheless, the services and the considerations are embedded in the way care is being delivered. So tell us a little bit about it, Massimo and Adelina.
Yeah, so in the Istituto Nazionale di Tumori, we don't have a specialized AYA unit. We have a pediatric unit, which ranges from children to 18-year-olds, and actually should be 15-year-olds, but we approximate 18-year-olds to pediatric patients, because we know that even if legally there's no guideline that says so, teenagers, even if they're 18, they need special care. And the doctors are all very aware and specialized, and not only doctors, because we do provide a holistic care as much as possible. They are specialized to take care of also AYA needs. And that's one of the greatest strong points of the Istituto Nazionale di Tumori. And another aspect was community, because in this hospital we have various projects that try to promote interaction and involvement of patients in the care of one another. In that sense, there is no loneliness. Even through COVID, this was possible, even if very hard and essential, because loneliness is a disease itself often.
Thank you so much,
And
Massimo. Yeah, go ahead.
yeah.
Go ahead. Sorry, I don't want to interrupt. Go ahead.
No, I was done. I know that we are out of time, so I'm not gonna like we don't have too much time. So
Yeah, but it is absolutely lovely to hear from all of you. So one thing that was, I think, really impressive for all of us, like we visited and we heard lectures from and presentations from fertility specialists, psychologists, mental health support. You had pet therapy, if I can call it that. You had your little turtle, right? We also had sports scientists and sport therapists and support available. So when we went there, I think we were quite impressed. But before we go into some of the learnings, I actually want to ask Adelina, what was it like for you when you first met the 30 young people involved as researchers in this project?
Well, it was a very incredible experience, because when you doesn't matter what place you have in this community, but it's very contradictory to say that it's a small but a very big world. So it's been very confusing to actually know the big dedication and the commitment that all these people had for all of us. So it's been very interesting and very nice to meet all of you, and to feel that there's people outside there that really care and really want to do a change that yeah, that's important.
So lovely. Thank you so much, Adelina. And Anna, you have been coordinating a lot of this work, and you were co-leading it with somebody else, but a lot of the work you were shouldering yourself. So what was it like to do this very novel research in these different countries?
I will say it was amazing. In just one word, it was amazing because it led me to participate in something big from my side of view, and I already started to advocate for this in Romania too. So getting all this knowledge from all these 5 hospitals made me to understand that the changes can be made, the adaptation of the doctors can be made. I found out from Italy that if you can not have a multidisciplinary team, we can have a case coordinator. I found out from Netherlands that the IA network that they created there, it's working for other hospitals, and each hospital is adapting the needs so they can get out the implementation. And from Belgium also, from Ghent, I saw that Johan is very implicated in this process, and also he is having a lot of survivors along with him. So this is something that was like so amazing for me to see how much survivors are also getting involved in the change. And that's it from me.
That's really lovely. Sophia, is there anything that really stood out to you? So you went and visited other countries as well. All of our hosts in these different countries had the opportunity to see how IA care is being delivered in other places. So I'm going to ask the same from Tim as well. What were some learnings that you might have?
Yeah, I thought it was a great opportunity to visit all 3 of the visits. So you could really compare and get a sense of the differences and also the things that we are alike in. So that was something, maybe a cliche, but the systems may differ, but as human beings, we are the same in essence. We are all young people that get thrown over by cancer, and we are just trying to navigate through life. So that really gave me a sense of community in a way that we're all aiming for the same thing. But as mentioned before, I think you really need those dedicated people from the bottom up that have a warm heart for this and really dedicate all their time, effort, and expertise to develop AYA care. However, you do need to have a system at some point to make this sustainable and future-proof. So it's not just for the patients that encounter this 1 or 2 or 3 or 5 people that really put their whole heart and soul into this, but you want to continue this, to offer this to all patients. So I think that's something we can really contribute to on an international level to make this system available for all AYA patients. So it's something that stood out for me. And also, I think we should really focus on how we can adjust things that already exist for all age groups, because there is a lot out there. It's just not always visible. So how can we take what's already out there and adjust it in a way that it's AYA-proof? So we don't develop everything from the ground up new, but see what's already there for other groups and make it sufficient for AYAs. So.
Thank you so much. And Tim, was there anything that really stood out to you in any of the other countries that you visited?
So working on AYA care in Belgium, you kind of have blinders on because you're focused on one system. So it was actually amazing to see how in other countries they approach certain difficulties. But I would also like to emphasize, as Sophia said, there are so many amazing people giving their heart and soul every day for providing the best care possible. And that was really eye-opening, and meeting so many survivors and seeing how many people are actually involved really makes me a small person in a big wheel or in a big world, to see how many people are involved. And that's the thing I keep from this whole project, is the people I met, to be honest.
Thank you. And maybe just back to Massimo Guglielmi again. I don't know if I know that implementation is going to be discussed with the healthcare providers later on this afternoon, but do you think that personally there is a place for you to be involved in your national AYA care services developments? Do you see that you will be able to have an influence on the local level?
I'll try to be humble. So I don't know if I will be, but I do put effort into helping in any way I can. And even if this year has been not the most impactful, these kind of projects do allow to have an impact. And especially going to these peer visits helps me to see like what works, like what the other hospitals that are excellent as well, like they have own niche features that we can bring back. And even if Italy works very well, there are other things that we can bring back, and we could talk about it. And because often it's just the healthcare professionals that have their glasses on with the filters and just look at certain things, but they don't have the patient view. And so I think being able to go there myself and have my own eyes and bring it back home can have an impact. Absolutely. And of course, it's not easy to have an impact, especially if you're young. But with this organization and the collaboration with Andrea Ferrari, for sure, I think that changes can be made.
Thank you. And while Adelina is answering us, can I just ask Asta to maybe pull up the next Slido, and we'll ask people to tell us in the audience what they think that the most unmet needs might be of AYA patients. And the Slido was already going. Oh wow! So people were already contributing to it. Okay, so Ada, any words from you? Where you see yourself in the future?
Well, I never thought that maybe I could work. Like, I would really hope to can help personally, and like to just simply maybe just talking and talking about my personal experience. But I never thought to maybe have the chance of working, or just simply try to be more involved in this. Would be for sure a pleasure, because it's a very big interest in my life. It was, and it will be, but I don't know, I didn't think about it, so who knows.
Thank you so much. And I think this is important to acknowledge that besides those young people who were trained in peer visits as a research methodology, and in this part of the qualitative research that we've done through the peer observation forms. There are lots and lots of other young people who were involved in this project in the countries that we visited, where we had the opportunity to meet with the local support groups and the patient groups. So thank you so much. A wonderful contribution from our panel of young people with lived experience. Don't go far, because maybe at the end of this webinar you will still be asked any questions. And if people would like to know anything, then please feel free to use the chat option. But looking at the Slido results here, actually, I think we are in a very good place with the recommendations that have been written and are soon to be published. So let's go straight into that, and I will ask Asta to share with us the next slide deck. Thank you. Thank you so much. So, and also I would just like to take 1 minute to acknowledge the amazing and beautiful artwork that you have seen on all the slides. They are the work of our community member, Andrea Ruano, and the slides themselves have been designed by Alina, who I don't know if she's attending this webinar or not, but we have some wonderful, wonderful people behind us. Okay, so there, sorry, I advanced the slides too much. So ta-da! Here we are. This is the first part of our recommendations. So this new white paper that we are about to publish with the recommendations for the minimum clinical standards or of care for adolescents and young adults with cancer come with a checklist and then with a roadmap. So I'm going to be talking to you about the checklist and then give over to Anna and Urska to tell you about the roadmap. This checklist first addresses the age-appropriate built environment, where it's very, very strongly recommended that AYA patients should be treated in departments with other patients of similar age. They also need social spaces where they can form friendships, provide benefit from peer support, and just spend time with their peers or visiting friends or other young people of their same age on the department. It's also absolutely important that the hospital has connectivity and that they are able to access Wi-Fi and also devices if available. And we also think that it's very important to provide a sense of control. And if they can, they should be allowed to personalize their hospital environment, to bring their own objects, stay in their own clothing and not necessarily in pajamas all the time, their own bedding, or, for example, have control of room temperature. And they do need some privacy as well. The second and very big part of the checklist is regarding clinical care organization and patient pathways. And as we've heard, it's absolutely essential that there is a multidisciplinary team looking after the needs of AYA patients that would include oncologists, hematologists, radiation oncologists, surgical oncologists, nurses, social workers, psychologists, and other specialists trained in adolescent and young adult care. And we purposely didn't add social workers and psychologists into a different category with supportive care, because we believe that it should be part of the clinical care pathway. And there should be dedicated and very thought through case management with a dedicated adolescent and young adult coordinator to oversee the patient care and transitions. Professional training should be available for AYA specialists. There should be ongoing medical education and courses and modules available for them to better understand the needs of this very specific age population. Clinical trials should be aware. Clinical trials should be explained, information given in a very clear and transparent way to AYAs. And there should be dedicated teams focusing on AYA participation, clinical and translational research on the department. We also believe that genetic counseling should be available for everyone. We also have received very, very strong feedback on AYAs having access to their own medical records. AYAs are mobile by nature. They maybe are diagnosed in one country, get their treatment in another country, have their follow-up in a third, get married in another one, start a family in another one. They are mobile by nature. And these should be recognized, and they should have access to their patient records. And second opinions should be encouraged. And this is again, in order to make sure that AYA patients are not treated as children, neither are they treated as very old adults, but we recognize and understand that they have a very strong desire to participate in their own treatment. And their pathways need to be understandable to them, and they should be encouraged and empowered to seek second opinion. They should, supportive care should be available within the clinic, which means pain management, palliative care, symptom control. Reproductive health and decision aiding tools or methods should be available in every clinic. Sexual health should be addressed by sexual health specialists who understand that even during the time of treatment, whether it should be months or years, sexuality needs to be addressed for the patient or for the couple if needed. And mental well-being should not be an afterthought. It needs to be a part of the clinical pathway. It's mandatory. It cannot be put in the corner. It cannot be something that might be provided by a nonprofit organization or by an external provider. This needs to be part of the clinical pathway. And here we are really speaking about a mental health assessment, psychological support, therapy for their patients and their families, and management of psychiatric symptoms during and after cancer treatment as well. And here's just maybe a note in brackets that sometimes the allowed quota for their whole cancer experience is very, very low. In some countries, maybe they can access 5 sessions, and if they use that up by the time while they are treated, then there is nothing left of it for their aftercare or follow-up care and managing late effects later in life. So this is a very, very serious issue, and we would like it to be appropriately acknowledged. Nutrition, as it was alluded to by Winette in the beginning of this webinar already, very important. And if kitchens are not available, then patients participating in the planning of the menu or having enough choices is of utmost importance, or at least, or having access to nutritional specialists who can advise them with knowledge and information. So again, they can be in control of their own health and their own choices. Exercise training and physical rehabilitation in the same vein. Late effect surveillance and long-term follow-up care should be available for everyone. And this does not just mean periodic check for the recurrence of the disease, but the late effect surveillance of all possible long-term effects for life for everyone affected by cancer. And we also need to acknowledge that these care pathways in some healthcare settings, from pediatric to adult care, or from AYA care to adult care, or simply from active care to follow-up care, needs to be facilitated by dedicated specialists. And then this last part of our checklist was actually built on things that we have observed during our peer visits, and we know that this is not out of turn, and these are not luxuries that we are asking for, because we have seen this implemented in many European hospitals, where there was on-site education and career support available family and social support, or childcare support for those young people who are young parents and they have dependables with them when they need to come in for treatment or come in for appointments or for follow-up. And advice on housing or access to low-cost housing or on-site accommodation near the hospital. The same with transportation support or legal advice on insurance finances and other matters. We've seen this in action. We know it can be done. So we wanted to put it in the checklist to make sure that it's not forgotten about. So this is the checklist, and you will have this in this beautiful document that is going to be published very, very soon. And now on to the roadmap. Oh, sorry, and just before, sorry, the last one word, we expect all of these services to be equitable and inclusive, answering the needs of a diverse European AYA population. And for this, please do go to this QR code and save the link, because this is an amazing work that also has been published within the European Network of Youth Cancer Survivors EU project. Besides the recommendations paper that was published, we also have a toolkit for healthcare providers and for researchers and for patient communities to strive for more equity, diversity, and inclusion in their practice. So on to you and to the implementation roadmap.
So for the implementation roadmap, we give some advices on how some of the checklists should be implemented. So the first recommendation is to develop a national knowledge hub for reliable AYA related information and resources. So the AYA needs specific resources, and we can link to various AYA initiatives, including EU-funded projects and their outcomes, and integrate the AI-driven language learning models tailored to individual health literature and learning needs. And how we can do that? The European Commission could support National Knowledge Hub through regular updates and annual review of the guidelines, or build a mechanism for AYAs, caregivers, healthcare professionals, or researchers to request inclusion of missing information. The second recommendation is to invest in training, education, and resource optimization for healthcare professionals. How it can be done is to establish private-public partnership to deliver such training models. We've seen that in Netherlands that they also have an AYA training for the hospital that they want to implement this, and create a matchmaking platform for services to help healthcare providers identify and utilize existing interventions that are proven effective for special scenarios, such as cognitive behavior therapy for AYAs experiencing anxiety related to fear of cancer recurrency. And it can be also done with personalized treatment, aligned intervention with the individual needs. The third recommendation is about integrate AYA-specific care across all cancer treatment settings. So AYA often are grouped with pediatric or adult patients based on age cutoff or available expertise in specific settings. And it can be implement strategies to integrate AYA care into existing treatment environments, such as educational resources that are age appropriate and relevant to AYAs, or designated area within clinics that cater to the needs and preference of young patients, tailoring them with amenities and environments that enhance comfort and engagement. Furthermore, it is vital that these settings are linked to the centralized knowledge hub that I talk about in the first recommendation. And as I said earlier, where a multidisciplinary team cannot be simply integrated, the introduction of a care coordinator is recommended. And the fourth recommendation is to expand access to mental health services, including on-demand counseling and support groups during and after the treatment. How we can do that? Maybe we can develop the development of key performance indicators for psychosocial support is recommended, and these integrate the KPIs into national cancer control plans to encourage local governments to prioritize and standardize mental health and social services ensuring they are distinct and tailored to the specific challenges faced by young cancer patients. Additionally, a care coordinator can facilitate seamless integration of these services into the patient's overall care plan, enhancing the accessibility and effectiveness of psychosocial support throughout cancer treatment and recovery.
All right, so I'll take over. Thank you, Anna, and thank you, Katie, for such a comprehensive overview of this work already. Let's go back to recommendation 5, please. Is it working? Oh. Voila, okay. So as you might have noted, these things are building off on each other. The recommendation 5 is to empower AYAs through participation in their care discussions and share decision making. So we often hear this, how can it be done? Of course, what we wanted to highlight here, even after having discussions with professionals and young people, whenever it's desired, possible, and in line with privacy and all the ethical recommendations and considerations, we should be including AYAs into the tumor boards, perhaps not in the initial discussions where the nitty-gritty things are discussed, but further down the line, it's really important to include young people in their care. In order to do this, a topic, again, close to my heart is health literacy. We need to make sure that if these people start becoming part of these discussions, we need to develop decision-making aids and equip young people with adequate tools for such meaningful engagement. Recommendation number 6 is to continue working on integration and interoperability of healthcare systems and digital health platforms. There's a lot of digital health innovation, a lot of it supported by the Commission. I think it's important that we, at least within the AYA sphere, can we think a bit beyond our projects. So an example here I want to highlight is Strong AYA, right? They're building PRO measures for young people. So let's do really keep in touch to make sure things are integrated as we move forward with the next steps, with the next projects. Let's make sure these things will be running seamlessly and actually promote reliable information sharing across different healthcare settings. Recommendation 7 is about further promoting research, really important. By the use of any digital health technologies, we should further strengthen research done with AYAs for them, not just to collect more data for the sake of collecting more data, write another academic paper, but it's really about seeing how this data can also be used. And this will be done, again, hopefully in the upcoming calls with the new projects. We can design, validate patient tools that can promote effective use of PROs, so patient-reported outcome measures. And it's actually, we can outline how those can be used for self-care. And lastly, also important, it would be to consider developing AYA-specific curricula, not just for the medical students, but also researchers, PhD students. Recommendation 8, before we open it up to the discussion, it's about just broadly further advocacy for the policy in practical changes in healthcare systems. We have great examples of system-level policies, such as the right to be forgotten. There's a lot more we can do. For example, one we highlighted was fertility preservation coverage, to any sort of policy that can actually lessen discrimination. And we're calling on, of course, policy makers, political bodies that can actually do these things. And before we conclude, we're actually gonna call our last panel of the day. I think we're running a bit behind the schedule, but we have a few great panelists representing different from different backgrounds, actually, that can really help us think about the implementation. We have this work, we've done it, we have the checklist, we have the knowledge. Now we need to go on to the implementation. So I'll warmly welcome all the speakers. Should we remove the slides? For
Yes,
the...
let's remove the slides,
you.
and then the floor is yours.
So thank you all for joining. I'll start. Katie already introduced you all briefly. So I would like to go around and ask you if you can tell us in a sentence or two how you actually, in what capacity you work with AYAs.
Who would you like to start?
You can go, Dan.
I'm a cancer physician and a researcher studying models of care, patient-reported outcomes in clinical practice, and providing cancer care to AYAs in 3 days of my working week.
Thank you. Tanya.
Hello, everybody, and thank you for the invitation. So yeah, I was diagnosed with breast cancer when I was 26. So I live as a cancer survivor since then, almost 16 years ago. And then this became my job, even though I have a professional background in veterinary medicine, and I did a PhD in neuroscience. Then I quit science and I became a professional patient advocate, of course, using all my scientific knowledge. And to this day, I was also a president of the Europadona, the European Breast Cancer Coalition, and the Europadona in Slovenia. So this topic is very close to my heart, and I'm very biased in this area. So I'm really happy what you all are doing for this young community.
Thank you, Tanya. And I'll just disclose, Tanya and I were just together in Slovenia, where we're beginning to build an AYA group. So this is extremely timely and super relevant. Thank you. Evelyn?
Well, thank you very much for inviting us and for this wonderful discussion we will have. In 2011, I started with a scientific background as a pioneer together with Winette van der Graaf and healthcare professionals and AYAs in the driving seat to set up AYA care in the Netherlands. And in 2024, there's a Dutch AYA care network of 77 hospitals in the Netherlands, where AYA care trained healthcare professionals are working actively providing AYA care. And I'm the proud director of the supporting team of the AYA care network.
Thank you. And last but not least, Johan, or I'm not sure if we have Rodica.
Good afternoon, everybody. So my name is Johan. I'm working as a cancer nurse manager of the university hospital. So I worked for a long time as a cancer nurse consultant for hematology and oncology, and mostly out of frustration. There were no services or no things for young people. I started to be very interesting into building up that services. But I'm also sharing together with Tim, who is the co-chair of the AYA movement in Belgium, and I'm also involved by EON's European Oncology Nursing Society, where we also really want to drive the AYA services across Europe.
Thank you. And then do we have Rodica from Romania by any chance? If not, I'll Katie.
We don't seem to find her. She
right.
was here for a while and then she's not here, but Anna will give her a quick call, but please go ahead.
Yes, so as I said, thank you. So we have seen this checklist and our recommendations or a roadmap of how we envision AYA services. But I wanted to open the discussion with a broad question. So from your experience, what are the key barriers in implementing such minimum standards of AYA care across different European countries, and how could we overcome some of them?
Shall I start?
Yes, please.
Okay. When our experience in the Netherlands is when we started enrolling the AYA care, we had two difficulties to overcome. One, there was no understanding and a lack of knowledge among healthcare professionals, among health insurers, and among administrators. Lack of knowledge and skills. They ask questions: why is this kind of age-specific treatment and care is necessary for this group, and why are these patients differ from compared from elderly patients, and does it create extra work for healthcare providers? And the second barrier to overcome was there was no funding for this care, and no funding of the organization of care. And we overcame these barriers really together with healthcare professionals and AYA in the driving seats, by lobbying and developing awareness by education and putting in research. We used to point out data of the impacts of AYA care for AYAs, what's the social return on investment of this kind of care for the AYA himself, for their caregivers, for the healthcare system, and for society. And then we organically can build together this network of hospitals providing AYA care. But I would like to add 5 competences, because you have to prepare to the barriers. We didn't know that, but we have to prepare for the barriers, to review them with evidence and expert opinions. You have to be dedicated through teamwork with AVAs and healthcare professionals, in close co-participation, facilitates the movement and supporting the team, starting a movement and seeking your first followers. And you have willpower. You have to have willpower in the whole team. Believe in the mission and the vision. Believe in the impact. Believe in social return on investment. Believe that data can enhance this movement. And finally, we discovered that not everything has to be done at once. It's too big for it. The vision is too big, too comprehensive also for that. And we learned to cut the entire vision into small parts and achievable goals. We learned to focus on the next smaller goal, and thus the bigger goal became achievable. So every hospital in the Netherlands has to provide AVA care.
Thank you. Amazing. So we heard lack of awareness of age-specific needs, funding, working together is really very important, breaking it down. And I think now we are finding ourselves in this sphere where we are beginning to have political buy-in, we have funding for this, like this project. So I want to hear from others, any other or additional or different barriers you have faced, Johan?
I think I want to speak from out of European vision and from the European organization. I think across Europe, there's a big difference in education, how education is delivered to healthcare professionals, if there even is access to healthcare professionals' education, and especially education will be key for enhancing services also for AYA. So therefore, I think it's very important as national societies and international societies, we stay lobbying with this great work, because this is also will become a great tool to lobby and to go to policymakers also in Europe. And for example, with the European Oncology Nursing Society, we have already for a long time, we have an educational framework that we want to adapt in the national societies, but also in the member states of Europe. But this is very difficult, but this will create opportunities for education, access to education, and we need to put these recommendations into these educational frameworks for different healthcare professionals and lobby with us and the implementation. So Europe has an assignment, I would say now, to put this in their educational frameworks and put it through to the national member states to enhance the education of healthcare professionals, to increase the quality of care for AYAs.
Thank you. Yes, so the importance of education. I'll turn to Tanya. I saw you nodding.
Yes, I just can continue where Johan started, and working on a European level with umbrella organizations, and then implement this on a national level, how to transfer this, and we just heard how Netherlands was struggling. Can you imagine all other healthcare systems how we'll struggle with this? So awareness first, setting the documents and advocate on a European level, and then setting the networks and implement this on national level. I think that we have a lot of work to do, and that we will have to work even more together, not just advocating for multidisciplinary teams in the whole cancer care, but now we are addressing a specific group, which is usually lost between pediatric and adult departments, or, you know, you somehow are in a very common cancer, like breast cancer, and you were diagnosed too young. So you cannot be diagnosed before the age of 30. So you are not included in any trial or in any perspective. And somehow, you know, we have to try to address this. And also for, let's say, young men who were diagnosed with other types of cancer. But we have to be really very vocal in this, and also to bring this to medical society, not just to politicians, but or also to cancer patient communities, but also to medical society. Until the past maybe 2-3 years, I barely saw any sessions about this and any big European or worldwide congresses. But finally, maybe last year and this year, we see the changes in this, or bringing either the fertility or mental health also within the younger patients to the main topics. So I think we will have a lot of work to do, but if we will work all together, I think that we have better chance to succeed and bring good practices to learn from one to another, what we can do on our national level. That will be really, really, really precious.
Thank you. And I think you already nicely passed the baton to Dan, who has been in this sphere for quite a while. And perhaps you can also mention some other initiatives that we know you've been involved with.
Well, no, thank you very much indeed. I won't witter on, as they say, about other things that I've been involved with. I think we can work together through NTIAC and other initiatives, and I think we can be very influential in the Joint Action for Networks of Expertise, which are going to, we hope and expect, be delivered across Europe. I think by being a strong European group together, we can contribute to global initiatives, of which there's one in much discussion at the moment. I think we can also hold on to the things that I find most exciting, most interesting, things that will bring other people to be interested in our area. And in these recommendations, I see this emphasis on shared decision making and really getting that right with young people as something that people will look at and say, okay, that's really interesting. I'd love to get a bit of that. It'd be really interesting to see how that would work. And the digital healthcare as well. I think we need to climb firmly onto the center of that agenda and think about how we use digital healthcare systems to enable a wider area of help and support and a wider area of advice and monitoring for patients who are dispersed with relatively uncommon illnesses and need to meet up with each other. I think Youth Cancer Europe has been a fabulous advocate of each of those things, and we should continue to do more of the same.
Thank you. And I'll then just continue with you. So we have seen the recommendations, the roadmap, the ideas put forward. There's one I think particularly relates to clinical care, which is including young people into those interdisciplinary boards. And I can foresee a bit of a pushback from the medical community. What are lay people going to be doing in those boards? I've sat on some myself. I know how they can be tricky to understand. How do you see that recommendation being perceived, received, or what would be the challenges, or how can we actually ensure meaningful participation of young people?
Okay, in brief, I think you have to make it very clear what the purpose of the young person being in the meeting is, or what the purposes of it are. And I think as long as it's constructive and mutually supportive and helpful, it won't be opposed particularly. I think that there'll be learning for the healthcare professionals, because you might think that those meetings are highly sophisticated, very scientific, very complicated. They're not, I promise you. They're quite informal amongst people who know each other well. And some of the discourse will be difficult. They're also not terribly well organized. And so if a young person thinks they're coming along for their discussion at 3:10 on Thursday, it might be 4:45 on Thursday before the meeting gets round to discuss their case. Yeah. And this is really important and relevant. It isn't that you could book a slot and come in and the thing will work to time. Because if your case needs half an hour, you want your case to have half an hour. And that means the other cases after it are going to be running late. Yeah. So there's practical issues. I don't think there's opposition to the idea. I think it's exciting and interesting, and it'll have challenges. I don't think there'll be opposition to the idea. There'll be concerns around it being mutually constructive, around the nature of these meetings being understood. And there'll be practical concerns about how on earth you organize it.
Thank you. That's really encouraging to hear, actually, directly from the clinical perspective. And I'll turn back to Tanya then. So you've been working in Europa Donna, which is a patient organization, a lot of resources you have available. How do you foresee some of these things being implemented, or perhaps you can even continue with the interdisciplinary board? What could be the role of patient organizations there?
Well, the thing is, what Daniel just started was that we have to build our own community. Once we got the seats, or once we got the recognition in all of different activities, from policy, research, advocacy, we have to train our community. So it goes back to us now. And here, I think that we will have to take this responsibility to do this, because if we have these seats, we want our representatives to be really eligible to discuss it and to understand it, and not just, like ticking the box, just, oh, we have a patient representative around the table, so we're fine. And because we want to really get to all levels, since beginning of the research, implementation, clinical decision-making, clinical boards, and of course, policymakers, we will have to build our capacities. And I think that younger people, we have advantage here because we have maybe more ability to learn, maybe we'll learn quicker. But somehow I see that we will also take the voice also of our older colleagues, which I find always very interesting, that we are, I call it two marginal groups, very young cancer patients and elderly with severe comorbidities. I think that those two groups, we are always somehow left out of everything, and we have to be even more vocal for us. But I think that as younger population, we can take advantage of this, of course, also with the digitalization and all the trainings that are available. And I'm super happy when I see new people coming to all of these trainings and resources that European community provides. I think this is really tremendous, and that we really need to take this advantage, because I think that Katie would agree with me that we miss some people, and we are all the same people everywhere. So I will also have to retire at some point, so we need new people.
Thank you. So yeah, young people, and Johan, young people are still going through the education. Young people are the future healthcare professionals, and you already touched upon the educational components. So looking at the recommendations, one of the points was particularly related to curricula, how we can do those better. What are the steps you're already taking there?
So I think from my perspective as a healthcare manager, I think like investing in training and education programs for healthcare professionals is essential, and to build on them. And if we, especially if we're looking what's already out there, it's important to bring everything together, because a lot of organizations do already a great work. But I think also it's bringing the communities, and also use the communities there and build on community partnerships in that. From history, healthcare professionals, we train with healthcare professionals, but I think we need to change this. We need to bring in the communities to support that training, to enhance that trainings. And for example, if you want to talk about cultural competences and communication skills, this will help the healthcare professionals very much forward, I think, to bring that community in the training and practice. And Then you already talked about it, is NTIAC. NTIAC would be a great example to bring everything together, because we have the communities, we have all the stakeholders, the healthcare professionals together, and we can think about like how we can enhance training and the competences what we need for the future on AYA services. And therefore, I think if cultural difference is also very important, it's very new now, and that is something we need to bring in. And then we think about like cultural sensitivity training, but also be thinking about the health disparities across Europe, but also nationally in your own country, in your own healthcare system. So therefore, we need young people to introduce them in training and use the strengths we all have together as healthcare professionals and young people with lived experience with cancer.
Thank you. And you nicely also lended me this opportunity to jump back to the recommendations. And the first one was to create a centralized knowledge hub. So we have a lot of resources. We heard that today many times. It's about putting it all together. We also heard nicely from our patients that at the end of the day, we are existing in different healthcare systems, different settings, cultures, but we're all humans with similar challenges. So in terms of research, Evelyn, how else, or how do you see this collaboration unfolding? How can we strengthen the research integration of AYAs in research as well?
Well, first of all, nothing about the AYA without the AYA. I think that's the main sentence I learned in this whole process, because it's their body, it's their lives. Who knows best? And then I would like to emphasize that research in co-creation with AYAs, just as education in co-creation with AYAs and expert opinion, are extractably linked together and are essential in a learning health system. In order to structurally improve AYA care and thus improve the quality of life of the AYA. And I would like to give you an example. One of the unmet needs of the AYAs is intimacy and sexuality during cancer and after cancer. It's one of their quality of life aspects and milestones, but are severely frustrated by cancer. But healthcare professionals didn't talk about this theme with AYAs and their caregivers. By conducting scientific research among healthcare professionals into discussing intimacy and sexuality and why they didn't do that, we understood that healthcare professionals didn't easily discuss it because due to shame, because they feel discomfort, because a lack of knowledge about the impact of intimacy and sexuality on cancer. And with these results, given by AYAs, we were able to develop education and interventions together with healthcare professionals and AYAs in order to make it a topic of discussion in AYA care and thus contributing in quality of life. So I believe that research in collaboration with healthcare professionals together with AYAs can be enhanced by, well, these central websites or hubs, providing opportunity for awareness, research and collaborations. It's more easy to find correct information and it enhances collaboration and it's also possible at international level. I would like to emphasize that not only the national research hubs, but also connecting it with European other hubs. I think
that's exactly what we're doing here, internationally speaking. Yes. Tanya, so you're unmuted.
Yes. I'm sorry, I will need to excuse myself because there's a bus waiting for me. So I really need to catch the bus.
Thank you very much.
I would just like to say that this is really great thing what is now happening, and what we are all trying to build, and I'm really looking forward to collaborate on with all of you. So I wish you really a luck, and this is my personally my favorite topic, and finally it's coming alive. So thank you, and I wish you a great meeting until the end. Bye bye.
Yes, so being cognizant of time, I would like to then wrap this up. I think what really came through for me is we need to continue working together. AYA need to be in the driving seat. I think we really did some great job here. Great work. People have felt empowered. I've seen a lot of the background that went into this. It's really powerful. So working together, believing in our vision, and I'll lean into the words of Evelyn, not everything at once, right? So continue breaking it down. And I think we tried to achieve this with these recommendations, having a checklist. So hopefully it will be useful for some people who are starting out, and I'll report back from Slovenia in a short time how we've done. I'll pass on to Katie.
Thank you so much, everyone. Thank you for our esteemed panelists. It was really important to hear from all of you. And as we said, there's a very strong ecosystem being built on the European level, which is providing the right impetus just right now in this time and this age to propel this movement forward. There's more need for research, and more research grants are coming out. We urge everyone to be collaborative. Please make sure that patients are not just asked for dissemination or for recruitment, because that's not the right way to go. Patients can do incredible work, as it is demonstrated by this set of recommendations, the checklist, the roadmap, and the white paper that is about to be published on beatcancer.eu. Maybe somebody could drop that in the chat, actually, so everyone can see that. And we look forward to collaborating with everyone. We look forward to the next stage of this particular EU grant as well. We look forward to looking at national healthcare systems and what local movements and initiatives can come to fruition in those different European countries as well. And just maybe a note that Dr. Rodica Kozmarovic had to leave because of a medical emergency. She apologizes, but she needs to get to the clinic. So we're really apologetic about that. But this is the nature of this and this work. So thank you so much, everyone. Please keep an eye on beatcancer.eu, on all our social media channels. Use the recommendations that were already published on inclusive and diverse and equitable cancer care, that a lot of the people sitting on this meeting today have already contributed to as well. And we're looking forward to publishing this great work for everyone, where patients were in the driving seat. And we have found amazing collaborators and supporters from the greater European ecosystem looking at AYA cancer care. So thank you, everyone.
Thank you.
Thank you. I see some people amazing celebration and a very, very big milestone. Thank you, everyone. Thank you, all the participants for this marathon. I know that we have run late. Thank you for staying on the webinar and not leaving too early. We hope that you have gone away with good things to reflect on and think about. Thank you, everyone.